Hello everyone, this is Dr. Divyam Goswami from Rajkot, India, and we are having a session on the healthcare paradigms comparing the medical systems of United Kingdom and India. And joining in from United Kingdom is Dr. Indira Vinjamuri, the Associate Dean of Royal College of Psychiatrists from Liverpool. I have with me Dr. Bhavya Bhansali, who is a very dear friend of mine and a colleague.
Hello, folks. I'm Dr. Bhavya Bhansali, and I'm co-organizing this meeting with my dear friend, Dr. Divyam.
Well, thank you, Bhavya. And I think we have a presentation from Dr. Indira. So over to you, Dr. Indira.
Thank you. Thank you so much for having me and for organizing this. So I'm the Associate Dean with the Royal College of Psychiatrists. I live in Liverpool and my day job is working in a crisis team in adult psychiatry in Liverpool. And we look after some really ill people. And that is what it's all about, looking after very sick patients and making them well. That's what gives us the pleasure. I look after the training program locally where I work. I'm the Director of Medical Education. And at any given time, I have about 200 odd resident doctors working with me. So we have psychiatric trainees. We also have foundation trainees, and we have some general practice trainees as well coming in to learn psychiatry. So I'm here today to talk about the psychiatric training scheme within the UK. As Associate Dean, I have recently modernized it a bit and made some changes as well. So the first couple of slides is all about why we need a curriculum that's up to date and how we redesign them and why. So why a redesign matters? Because medical education is evolving. And then, we have patient complexity and physician burnout. They demand change. Traditional curricula overemphasize service delivery at the expense of reflection and innovation. This is more to look after resident doctors and help them learn. We need to train physicians who are clinically excellent, intellectually curious, and deeply human. So the clinical core of our curriculum, it uses milestone-based frameworks. We integrate simulation, direct observation, and structured feedback. And we emphasize adaptability and not just checklists. There is a need for us to understand evidence-based medicine, and research should be embedded longitudinally throughout somebody's residency and not just as an elective or a separate thing for somebody to learn. We need to offer people protected time and mentorship to do what they're doing. We need to encourage quality improvement, health equity, and translational projects. So humanism is at the bottom of everything. We have to use narrative medicine. We have balance groups for our residents and reflective writing. We prioritize wellness and emotional resilience, especially for psychiatrists. We teach cultural humility and trauma-informed care, which is at the heart of everything these days. So a good curriculum should be projecting a vision for the future. We should have clinicians who are competent. We should have curious scholars, and we should have healers who are compassionate. So we don't just train doctors. We shape thinkers, advocates, and humans. So a little bit about the psychiatry training in the UK. I did my undergraduate education in India. I studied from Bellary Medical College in Karnataka. I'm very used to the Indian system. And after I finished my MBBS, I came over to the UK. I did my PLAB exams and then got GMC registration and then started my psychiatry training. I had been working in a neuro center in India. And that's where my interest and experience in psychiatry began. I think one of the advantages in India is that you have neurology, neurosurgery, and psychiatry together, and it keeps the neurosciences together. Whereas in the UK, mental health is almost separate. So there is a curriculum nationally from the Royal College. We all work within the National Health Service, which is like the government service in India. There's very little private work going on. Treatment is free for everybody here. We have some inpatient units, and then we have outpatient treatment as well, community mental health teams and things like that. And our training scheme aims to put people through experiences in all all specialties, inpatient, outpatient, acute adult, chronic adult, older people's, child and adolescent, intellectual disability, and so on. So, as per the World Federation of Medical Education, we need a comprehensive curriculum. So the journey for somebody is they do 4 to 6 years of medical school. Then what we call internship in India, that's foundation training, and that's 2 years here. And then you go into a psychiatric placement, and there's 3 years of core training, during which time somebody finishes their exams and things. And then they move on to a registrar post or higher training, at the end of which they're eligible for a consultant post. It is a long journey, but it makes people quite competent. So here it is broken down a little bit more. So when one graduates from university, here in the UK, you don't automatically get posted into internship like in India. People have to apply to go into foundation training, and that can be anywhere in the country. So from that point onwards, they get out of university and they start working within the National Health Service. Foundation year 1 takes them through a couple of placements. So each placement here is about 4 months. They have already a split between medical specialties and surgical specialties, even from the beginning, but if people know what they want to take on. At the end of FY1, they get GMC registration, and then they finish FY2, during which time they put their applications in for higher specialist training. So they get into the core medical training for whichever specialty they want to. And within psychiatry, it's core medical training year 1, year 2, year 3. And then once you pass your exams at the end of CT3, you go into higher specialist training year 4, year 5, and year 6. All of the CT1, 2, and 3 posts are generic, and people rotate every 6 months into various different specialties. And then they can choose their specialty at ST4, which will be adult psychiatry or old age psychiatry, child and adolescent, intellectual disability, psychotherapy, or forensic psychiatry. Those are the approved specialties at the moment. So at the end of ST6, or in case people want to do more than 6, so if they want to do a dual in adult psychiatry and old age psychiatry, that will be 2 plus 2. If they want to do psychotherapy and adult psychiatry, that will be 2 plus 3, something like that. So some people will go on a bit more than ST6. At the end of that, they get their specialist certification or CCT, and they'll be eligible for a consultant post. So the overview, within the first 3 years, 6-month placements with on-calls are organized for everybody. They do adult inpatient and outpatient, old age, child and adolescent mental health, learning disability, and other specialty posts such as the early intervention team, perinatal team, brain injuries unit, one thing or another. And then ST4 to 6, they can go into a specialty of their choice. That's the training pathway again. In another picture. So they can start doing the MRC Psych exams from around here. Some specialties like child and adolescent, they can do a run through. They don't have to go for interviews again at ST4 level, and they can do right the way from specialty training year 1 to specialty training year 6. So the curricula itself, this is available on the Royal College for everybody to see. There's a core curriculum, and then we have the specialty curricula for all of the mentioned ones. And then we have subspecialty curricula or endorsement curricula for addiction psychiatry, liaison psychiatry, and rehabilitation psychiatry. So there's a snapshot of the website here, and you can see what's covered. Sorry, I think I just clicked on the link as well. So that's how it is. So back to our slides. So in the curricula itself, we have 9 high-level outcomes, which are divided in this manner. And each of the high-level outcomes are subdivided into some more little bits like clinical skills, complexity and uncertainty, etc. And overall, we have about 69 key capabilities that every trainee has to attend. The assessments that we do are workplace-based assessments that's done on an everyday basis. So assessments are broken down into summative assessments and formative assessments. The summative assessments are what people finally do in their exams, and the formative assessments are what we see on a daily basis. So everyday examples of seeing a patient, presenting the case, etc. People have to maintain a portfolio. So that's a national one. It's called Portfolio Online, and every resident doctor will have a portfolio. Then the exams, of course, I'll talk about that in just a minute. Then they have their training scheme, and throughout their training scheme, they have a clinical supervisor that looks after them. There's a clinical supervisor who's usually also the psychiatric supervisor, and all psychiatric trainees have a one-to-one supervision once per week for an hour. Then there's an educational supervisor who takes care of their portfolio for the first 3 years. And then once they get into higher specialist training, they'll have another educational supervisor who looks after what jobs they're going into, make sure that they get a variety of jobs, etc. And then at the end of each year, they have supervisor reports submitted, and then they have an ARCP or an annual review of their clinical progression. So the workplace assessments, there are plenty of them. We have a silver guide for psychiatry, and that specifies how many of these assessments each resident needs to do. So the ACE is like a long case. You see a whole patient, and you have to have your supervisor sitting next to you and observing the whole thing. So we need to really make sure that the patient is not talking to the supervisor, because they know that the supervisor might be the more experienced one or the consultant, and we need to make sure that the activity happens with the resident doctor, with the consultant only supporting and giving feedback afterwards. I do a lot of video consultations because of the wide geography that I cover, and sometimes doing an assessment on a resident on a video call is much easier because I can say hello in the beginning and then turn my video off and then watch the whole conversation and say hello in the end again. And that's less sort of intrusive. Likewise, a mini ACE is something where, people have a smaller encounter, maybe just a cognitive assessment or a mental state examination or something like that. So these are observed. So the assessor has to sit with the resident. And then you have case-based discussions where in the weekly supervision that we have, we can bring in cases. The junior doctor is expected to bring about 2 cases and then pick one to discuss. So you can discuss a reflection, formulation, or a management plan, which then can be marked. Then there's a case presentation. So this is presenting a case to a huge audience. The case presentation has to be followed by a good formulation and diagnosis and a management plan. That gets marked as well. People have to do at least 1 per annum of that. Then there's a journal club presentation where people present papers. Then we have the direct observed procedural skills. And quite often in psychiatry, this is only ECT. Then we have a multi-source feedback, which is called a mini peer assessment tool, where the resident doctor has to take feedback from numerous people that they work with, which includes the consultant, the secretary, nurses, social workers, and all other colleagues that they may work with. An aggregate is collected and discussed at the end of placement. There's an assessment of teaching tool where they're expected to deliver teaching to other medical students or other junior doctors if they're senior grade, or nurses or a multidisciplinary team, and that can be marked. So the supervision structure I mentioned to you, there's clinical supervision, which happens on an everyday basis. Then there's weekly supervision with usually the clinical supervisor, then an educational supervision with the college tutor. Then they have a training program director who oversees, how many trainees are around and what placements can be offered to all of them. And then there's provisions for out of program, so people can take a break in between, people who want to work less than full time. So that's becoming increasingly popular these days. People work 3 days or 4 days, just to have a good family balance or to take care of their health, etc. We facilitate all of those. So we have an MRC Psych course. The MRC Psych course is usually regional. There is a syllabus which is national, and then people cover some topics regionally. So the northwest of England, for example, where I work, they will have a regional sort of MRC Psych program, and they will have about 6 days, 6 whole days in a 6-month period, during which they will be lecture-based teaching. And then we have a local academic program. And this, I look after the local academic program where we are. So what happens is this. So let's say the topic is schizophrenia. These are all set. So we cover the entirety of the syllabus in this. So if the topic is schizophrenia, then one of the resident doctors will present a case on schizophrenia. The next resident doctor will present a journal club on schizophrenia. Then a consultant teaches on schizophrenia. And then we have some MCQs at the end of it. So we have all our topics covered on a weekly basis. And wherever I am, we do it on a Tuesday morning. And then we have the regional dot sessions as well. So the MRC Psych exam. So the written exam, so anybody can take the written exam as long as you have a full medical registration. So lots of people do it from abroad as well. But a paper B can only be taken if they have 12-month experience in psychiatry. So they have to demonstrate that they do have that. Then when this is over, people do the clinical exam, which is the CASC, Clinical Assessment of Skills and Competencies. They need a pass in paper A and paper B, and at least 23 months in psychiatry. And once they pass the CASC, they can move on to higher specialist training. So people can have equivalent competencies if they're doing this from abroad and they need a sponsorship letter, and they can take the exam from wherever. Paper A covers behavioral sciences, sociocultural psychiatry, human development, basic neurosciences, clinical psychopharmacology, classification and assessment in psychiatry. And paper B covers the rest of it. So mainly statistics, how psychiatric services are delivered, and then all the subspecialties, etc. The CASC is the clinical exam. We used to have to present a long case, which is not the case anymore. They look at evidence-based medicine, and they find that marking a long case is very subjective, and everything depends on the type of examiner somebody gets. So now the clinical exam is made up of 16 CASC stations. So they have 5 stations focused on history taking, including risk assessment, 5 stations focused on examining a patient, physical and mental state, including capacity assessment, and 6 stations focused on patient management. So these stations can be anything between 10 minutes or 10 plus 10, depending on what the station is all about. You'll find sample questions everywhere on the internet. So for people who don't go through higher specialist training, there is another route to registration, which is slightly harder. People have to try really hard. So this is the equivalence process for those who have completed a GMC-approved training, but they haven't gone through the ST 4 to 6 years. There'll be lots of details about this on the internet as well. So for people abroad who want to have some experience in the UK, the college introduced something called a medical training initiative. This is an opportunity to train in the UK for 2 years. What they want is at least 3 years experience in psychiatry. From wherever they're coming, we have people coming from all over the world. They need to have a good score in IELTS. And usually applications open in the autumn for the next August. So the 2 years will be in junior doctor jobs, the junior doctor jobs from the UK. And they will also have all the structures that I've mentioned in terms of supervision and a portfolio, etc. Usually, these jobs are offered when we have gaps in our training scheme. So we have to prioritize UK graduates first and fill the training scheme. And then the MTI slots are available for people who want to come in. And if we have the gaps and if we can match their interests. So let's say somebody's coming in from abroad and they want to do child psychiatry or old age psychiatry, we need to try and match their preferences to what gaps we have. So we have area-wise health authorities or health boards, which is our National Health Service. Locally for us, it's Health Education Northwest. Likewise in the rest of the country. And then we have a School of Psychiatry for each of our areas, which looks after all the residents within that school, which is regional, and they will have a head of school, and they will have TPDs that look after the entire program. They will keep track of how many jobs are available, how many training posts are available, and they look after the training program as well. And then people come and work in local trusts and hospitals where we actually look after them on a day-to-day basis. So there was a Choose Psychiatry campaign, which which was designed to inspire medical students and doctors in training to consider a career in psychiatry by highlighting the specialty's impact, diversity, and meaningful patient relationships. So they had lots of people give examples of what they've learned in psychiatry, etc. at that point. So the undergraduate program, what do we do with the undergraduates and how do we teach them? So we have students on placement from universities around us. So at the moment, we look after 2 universities in our area. They can come to us from year 1 to year 5. And one of the universities, we have them in year 4 and year 5. One of the other universities we cover, we have them all the way from year 1 to year 5, spending small amounts of time in psychiatry. We have undergraduate tutors. We have annual quality visits from the universities coming in and checking what placements we offer them and how we look after them. And we take part in university interviews where there are interviews to select into a medical school. So they will be the usual eligibility and exams as well, but they have local interviews. We also take part in examining them, and the undergraduates can also participate in research right from that stage. So once again, the RC Psych Choose program also links into this, and people hear from many, many people about what their careers in psychiatry might look like. Continuous medical education. So the Royal College website has e-learning modules. It's called RC Psych Learn at the moment. There are 200 learning modules. And we have to, even as consultants, we have to do CPD submissions, and we have to have clinical, academic, and professional activities that we demonstrate on an annual basis. So that's it. That's it, really. We have to really be really, really careful that people are encouraged to talk about their mental health. There is no health without mental health, and we have to all together stand up against stigma and take care of ourselves and the population. That's me.
It was a wonderful presentation, Dr. Indira, and we're able to understand how the system works there in UK. So I think I would keep it interactive, and we can just have a compare and contrast sort of 5 to 10 minutes for the Indian system. Like in UK, you have the foundational training, which is of 2 years. We here in India have the internship, which is only 1 year. So I think we have a better chance at choosing the specialty in UK if you are going through the postings and rotations for 2 years rather than 1 year.
There's pros and cons to both systems, really. I think the reason why the foundation training was increased to 2 is because it was felt that just 1 year of internship didn't make people independent enough to make the decisions and be practitioners. Because the minute you get into post-graduation or you get into a specialty, it's almost expected that you run outpatient clinics, isn't it, under some supervision, but you've got to be there, you've got to do the right thing. So I think they looked at patient safety, any incidents relating to patient safety and things, and they decided that maybe 2 years is better. So that the first year is wholly focused on learning, and then people start putting their applications in and start getting distracted from the second year, but it gives people a wider outlook. What also happens in the foundation training is you've heard of sort of broad-based learning and broader competencies, and the wish is that everybody should know a bit of something. You can't get super specialized. So the foundation training program between FY1 and FY2 make sure that everybody has some experience of working in general practice. So to make sure that they're able to understand primary care, what primary care provides, because all our subspecialties, we are all within secondary care, aren't we? We are not available to a patient as soon as they want us. So this is more for people to understand what a general practitioner can offer. These are the people that the patients will go to see first. So I know, you have the primary healthcare centers, don't you, in India? And it's similar to that. So that'll be the person that takes care of literally everything. Yeah. So that sort of situation.
And you do get the GMZ registration after 1 year of foundation training, isn't it? So after getting the GMC registration, you can choose to work as a general practitioner, if I'm not wrong.
No. So it's the same process. You have to finish your FY2 and then apply to go into general practice. That's a
Okay.
training scheme in itself. It's not as big as the other training schemes. It's only about 2 years. And if you practice for 2 years, you can become a general practitioner. But if you want to look after junior doctors, if you want to be a trainer, you have to then do the MRC-GP exams. So that's not compulsory for everybody. People can work as a general practitioner. And then for those who want to study further and get the MRC-GP exam, they can then become trainers and they can have junior doctors working with them.
Yes.
That's
So
also all, it's all National Health Service, though. People can't
okay.
set up private practice wherever they want. They all have to like align and work within primary care centers that are set up. So it's just like the primary care centers in India, but there will be one per catchment area. So where I live, for example, I've got 1 to about 3 GP surgeries around me that covers the entire patch. So we can go register with any one of them.
Yes. So if I'm not wrong, GP is a specialty training in itself, which is not the case here in India.
Yeah.
And regarding the specialty training that people take after gaining the core training in psychiatry, I think there are more number of people opting in for specialty training in UK than in India, because in India we have 3 years of MD or DNB training, and then very few people, very few residents go on for having a specialty training that is the DM or DRNB.
Yeah. Here, there's no option. Otherwise, you don't get a consultant post if you've not gone that
Okay.
far. People
So
stagnate into what's called staff grade jobs or specialty posts. They're called SAS doctors,
okay.
specialty and associate specialist doctors. Yeah, staff grade and
So
associate specialist doctors. So they are like always one step below a consultant post. They always have to work under a consultant supervision.
yes, so there is an exit after the core training, but then you stagnate to become an SS doctor.
Yeah. Most people in this country do that because they haven't got their exams. Because the exams are very tough. The pass rate is only about 47% every time. They're very expensive as well. And although people can take multiple attempts, there's a limit to that as well. And many people drop out of training at the end of CT3. They'll carry on doing staff grade jobs and still take the exam in the background. So it's an apprentice style model here, So what happens is you get a job, you do the job 9 to 5, and then you do all your own calls. And then you get half a day out to go and attend the MRC Psych course. You get 1 day out sometimes to go and attend the MRC Psych course, and you have to take study leave to go do your exams. So it's not like India where you have your curriculum, you do all your placements, at the end of it, you do exams and you're off. It's not like that. We just have to run the service nonstop. In the meantime, people can take study leave. You study in your own time. You take study leave to go off and do your exams. That's the way it works. You just nonstop. So for the 3 years, you'll have your placements back to back to back, whether or not you pass your exams. At the end of 3 years, if somebody hasn't got all their exams, but they're nearly at the cusp of it, they just need a little bit more time. Sometimes they're given a 6-month extension, and they can still stay within a training placement, and then they can get their exams. So you might have noticed that we don't have neurology. I feel like that's a bit of a loss for us. We're missing neurosciences that way. I know in India, whenever I used to work in psychiatry in India, we looked after epileptic people as well, and we used to prescribe anti-epileptics. That's just not the case here. We just don't look after anybody with any neurological problems, and it's just mental health. On the other hand, we are very strong on psychotherapy. The training scheme itself, I mentioned Balan groups before. So in their first year as a core trainee, they go through at least 25 sessions of a Balan group. So are you aware of Balan groups, and have you attended them?
No, I'm not aware of them.
Yeah, so Balan group is where it's all about, it's touchy-feely, it's all about your thoughts and feelings, because as a psychiatrist, you come across so many situations where lots of things hit home. You may remember how it affects you, when you've spoken to somebody about trauma and what they've gone through, how it makes you feel, and how that drives you as a clinician. A Balan groups brings together all the core trainees within that scheme, which is about whatever, some 10 or 12 people in one group. everybody coming in, there'll be a facilitator who's usually a psychotherapist that lets people talk through the thoughts and feelings and what happened to them when they were seeing a case. So everybody gets to present a case every time they come in. This is not about case presentation, formulation, diagnosis, and management for the patient. It's more about us and our thoughts and feelings and reflecting on what it made us feel like. So how many times have you felt angry when you've seen a patient? How many times have you felt upset when you've seen a patient? That's the whole definition of an affective disorder, isn't it? You've got a manic, angry patient. Haven't you wondered what you're doing in this job? Why are you getting abused and insulted by them? And this is the sort of thing that you need to get rid of before it consumes you. So the Balance Group allows that. It allows people that safe space. And it's very easy to set up. You can do it where you are as well. Get a group of people together to it's like a detox, almost sit there and sort of talk through things. Okay. Even at our level, at consultant level, we have a Balance Group for suicide support. When your patient takes their life, it ruins us, doesn't it? It's just one of the worst outcomes. And homicide is the next worst, of course. But when our patients commit suicide, it's a big loss, not only for us but for the family, and then we obviously have to write reports, go to the coroners, where we have to give evidence, and there'll be investigations within the service, there'll be investigation top to bottom, sometimes complaints from the family, and we have to really deal with quite a lot. And our trust has set up a suicide support Balance Group for consultants, at every level in our lives. However far we've got to, you just feel miserable about not doing the right thing for a patient, or things that we didn't have control of. For example, we work in a national health service, which is government service, and at any given point in time, we have about 20 people waiting for a bed, right? Somebody acutely unwell needs to come into hospital. We don't have a bed for them, So we have to wait for somebody to be discharged for us to be able to make a bed for them. In the meantime, from my crisis team, we go out and do daily visits. We make sure they swallow their medication. We do what we can, within reasonable limits. So that sort of Balance Group is really helpful at any stage in life. And you need to start to explore if you can set one up. And that's very psychodynamically based. I'm afraid it's all about thoughts and feelings and how people develop as clinicians. Okay. So the first year as a co-trainee, they do Balance Groups. That needs to be signed off in their portfolio as well. And then the system has it inbuilt for people to do 2 short cases in psychotherapy and 1 long case in their CT 2 and 3 years. So they can pick any modality depending on who's available to supervise. They do CBT, CAT, IPT, psychodynamic therapy, etc. Quite often the long case is psychodynamic because you need that length of period for psychodynamic. You might have heard of all sorts of very brief psychodynamic interventions, 6 sessions, this, that, and the other, but that's all done to make sure the waiting lists are not too huge and we support people. But for training purposes, I think it's a minimum of 12 sessions of CAT or 12 sessions of CBT, 12 sessions of IPT or something like that. That's what you need to do. So that is inbuilt. And if you're on a training scheme, the training program directors will make every effort to make sure that you've had that therapy. We will release you from your timetable for half a day or whatever that requires for you to see a patient. And then you have 1 hour supervision for the patient. So we will make sure that we allow you to go away and do that. So we are a bit more strong on formulation and the psychological nature of a mental health problem. But I do feel like I miss out on the neurology and the neuroscience part of it as well. And it's a fine balance, isn't it? We just have to refer on to somebody else. We have 1 brain injury unit within the whole of our trust. We are a massive trust covering a massive geography, and we have 1 brain injury unit because it's sort of heavily neuropsychiatry based. And there aren't that many neuropsychiatrists around also because mental health is more mental health here.
Yes, so I think we do have this provision of posting into neurology units, but it's not everywhere in India. I mean, it's there in NIMHANS, which is the Apex Institute in Bengaluru, and it may be there at some other hospitals as well. But like, say, for example, at my institute, we don't have a dedicated rotation in neurology unit. But nevertheless, we do see patients of neurology like the epilepsy or the Parkinson's or sometimes the essential tremors. So we do get to see the patients, but we don't have a dedicated posting as a part of our residency program in the neurology.
Yeah. What we allow is something called special interest sessions for those who are higher specialist trainees. So they can go away for 1 day a week to shadow neurology or other specialties that might be useful for them. So the old age psychiatry people, for example, they'll go into geriatric medicine, end of life, this sort of thing. They will do attachments with them, and we release them for 1 day of the week to do a special intercession and research.
My colleague Dr. Bhavya has some questions, so over to Bhavya.
Hi, Dr. Indira. As you mentioned that there is a strong GP culture in the UK, whereas in India, the patients have direct access to the specialists.
Yeah.
So how does that affect the access to the mental health care?
Access to mental health care is really difficult here. However, because of the way the provision of secondary care is designed, so every single person in the UK will have a GP. Okay, anybody who's in the UK will need to be registered with a general practitioner for anything and everything. Okay, so you can't go and get a blood test done for yourself. The best thing you can buy in a pharmacy, for example, is paracetamol, ibuprofen, maybe slightly stronger painkillers. You can maybe get cocodamol. You can get lansoprazole. This is it. You can't buy anything else for yourself. I can't buy anything for myself either in a pharmacy, and it has to come from a GP. So you have to go to your general practitioner for almost everything. For a general practitioner to then refer to secondary care and for you to wait on the waiting list to be seen, it's quite hard. And the general practitioner is expected to. So the NICE guidelines, if you see the NICE guidelines for depression, for example, will suggest that the GP is able to prescribe your initial SSRIs or, change the medication once or something, try that, and then refer on to secondary care, which is fair enough, because otherwise, once they come into secondary care, they get stuck within our system. We need to see them and move them on. But recently, over the last couple of years, especially when COVID hit us, we have 999 is emergency, right? So we've built on that. So 999 is absolute emergency, and 111 is needing immediate help, but not something that an ambulance needs to rush for. So 111 used to be just for physical health problems in the past. So around COVID time, we've made that big difference, and we've got 111, option 1, physical health, option 2, mental health. So now anybody from anywhere can ring 111, option 2. They might be holding on to the phone a little bit, but it puts them straight through to one of our mental health practitioners. It'll be like a band 6 nurse or somebody that'll take a call, that'll triage it, that'll understand what's going on. Lots of them will be just wanting to cry because their cat died or something like that, so that they can sort. And then if there's a real genuine need, if somebody's psychotic, they'll organize an appointment immediately and they'll get seen within our system as well. If somebody's acutely suicidal, actually self-harmed, they'll get seen within our service like ASAP, either that day or the next day or something. So there's 2 routes now. Primarily, they'll go through their GP. But if something's extremely emergency or somebody has an urgent need to be seen, they can ring 111 option 2 as well.
Right. Thanks. And I had another question. I mean, in India, we have this provision of consultation liaison in our medical college. So do we have such a thing over there?
Tell me more about that.
Yeah. So
consultation between departments, is that what you're saying? Or?
Yes, between the departments.
So liaison psychiatry is well established within the UK. Every general hospital will have a liaison psychiatry department with 1 or 2 consultants and their registrars and a whole team of nurses and social workers and everybody. So whenever there is a problem which needs mental health care within the general hospital, they will call the liaison team, who will then go and see the patient and do the needful. If they need further ongoing care when they leave hospital, so when they leave the general hospital and they have ongoing mental health care, then it'll come down to us in secondary care. It'll either come to me to the crisis team, or it'll go down to the early intervention team if it's a psychotic illness or something like that. But every single general hospital will have an established liaison psychiatry team. And then when we're on call, we all cover the general hospital. So on call is distributed to all the resident doctors and all the consultants as well. And whenever there's an emergency in the general hospital, if we are on call, we cover that.
Right. Thanks a lot. Over to Dr. Divyam.
Yes, so I wanted to ask about the pattern of examination. Like in India, we have a 1-day high stakes examination, and it's more of a summative assessment. So, and I think in UK it is more of a modular assessment. Like you don't have that high stakes 1 day exams over there in UK.
We do have them. We have formative and summative assessments. So the CASC exam, which is the clinical exam, that's like the do all end all thing usually for people. So once they have passed their paper A and paper B, they do the CASC. And if they pass the CASC, they move on. It is a high stake exam. And what the formative assessment helps people move on from one placement to the other and looks after them on a daily basis. But they do have to do the summative exam to move on. But it's over time. So they can do the paper A, and then they can do the paper B in any order, and then they have the CASC exam, which is really the decider.
And I mean, the time period during the residency, is it assessed or you just base the assessment on the examination?
The formative assessment is checked at the end of every year. So at the end of every 6 months, they have a clinical supervisor report. They have to check how many assessments they've done. There's a minimum number specified in the silver guide. So for example, it'll be 3 long cases and then 2 short ones like the mini ACEs, and then 1 teaching AOT, 1 case presentation, 1 journal club per annum. So they'll check the tick boxes. They'll see how much psychotherapy they've done as well. There's assessments for the psychotherapy balance groups and the cases they do as well. So there's a list of things they need to have done to move on to the next year. So for the first 3 years, it's every 6 months, checks are done. And then at the end of 1 year, they have this ARCP and they have to pass that to progress. If they haven't done an audit, for example, or they haven't done teaching or something, then they can hold it till they've achieved their competencies. So sometimes they may not have just finished 1 form, or they may not have put in a certificate, which is still not available for teaching or something like that. So they'll give them something like a few weeks to put in all their stuff into the portfolio, and they'll let them pass, and then they'll move them on. But there is a check at the end of every year for them to move on.
I would like to inform Dr. Indira that here in India, I think that the government is trying to align the Indian system as well with the system of the Western countries, including the United States, UK, and Australia. And as a part of it, they are planning to introduce an examination in undergraduate, at the undergraduate level, called the NEXT exam, that is the National Exit Test. So they will have this test before internship. So that would be before the foundational training over there in UK.
Yeah.
And after that, so the part 1 of the examination would be before the internship, and the part 2 of the examination would be after the internship, and the part 1 would be purely theoretical, and part 2 will be practical.
Clinical.
And I think what I get from studying the medical system of the Western countries, I think the base of it is the clinical vignettes or the standardized patients. We don't have that in India. So
I didn't. When I did my MRC Psych exams, we just had patients pulled in, volunteering patients from any ward. That's how we did it. But they found that it's very subjective, like I mentioned before. And having standardized, it used to be patients, now it's just actors. Having standardized assessments has been shown, with evidence base. They think that might be a better way forward.
Yes, I think, I'm not sure, but I think they're planning to introduce that in India as well. And I think they should, because it is more evidence-based if you are introducing patient actors or standardized patients for the assessment of the residents or for the medical students.
Yeah. What happens is you could go through the entirety of your residency program without seeing somebody with PTSD, for example. But because that's a thing that will be assessed in your exam. So like we have 16 stations, and there's a high possibility that you'll get a pregnant woman in it, or you'll get somebody with PTSD or something. So the residents will seek out these cases, and they'll see them and they'll learn about them because it's going to come in the exam. Because depending on where people are working on an everyday basis, we have lots of rural and remote places. We have lots of really inner city urban places, which is full of drugs and that sort of scenario. And then you'll have the coastal ones where there are lots of old age homes, a lot of people with dementia. So there's a wide variety of patient population in different places as well. But because they're all assessed in the exam, everybody will make an effort to make sure that they understand those scenarios and get to terms with them. Yeah. So the next exam that you mentioned, that is what the UK MLA is going to be all about. So people from India, if they want to come and practice here, the PLAB's going to be replaced with the UK MLA exam, which is the exit exam for all the medical students here. So they'll have to, that is same as the USMLE in the USA. So they'll have to do that exam. That'll be our exit exam.
Yeah. I also wanted to ask about, since you mentioned UKMLA and the international medical graduates, if they want to come from India and practice there in UK, there is some bill passed by the Parliament of UK prioritizing the experience in UK or the international medical graduates.
Yes, it's very much in discussion. What happens at this point is we have this exam called MRSA. Have you heard that? So that's like a written paper. That's the entrance exam for postgraduate entry here. And rightly or wrongly, it's just the score on that exam that matters to get into postgraduate education. And we've seen that people from abroad who are used to rote learning and learning for exams were getting higher scores than the UK graduates. So UK graduates, people who finish foundation years, foundation FY1 and FY2, were left with no jobs because it was purely based on passing that paper, and some people are better at passing written MCQ type papers than others. But if you have an entire population you have educated to the point of FY2 and they don't have any jobs to go to, that's really sad, isn't it? And that's one of the reasons why they had to bring in something to allow these people coming out of university, coming out of medical school to actually progress. But the NHS here is made up predominantly of IMGs, predominantly of people from abroad, from our subcontinent especially. And it'll be a huge loss if we don't have that population working within us. It may not be possible to fill all the postgraduate seats with just the UK graduates. That's also another issue. And I just wonder whether some balance will be there in the end. I feel like if they take just UK graduates, we're going to be left with lots of gaps, lots of vacancies. It was these vacancies that brought in a lot of us from abroad in the first place. So I don't think the NHS is going to run totally on UK graduates. There's going to have to be some way of bringing in graduates from outside as well. But it's a process and we'll keep an eye on it.
And you mentioned about the specialty training in, I think, psychotherapy. Yes, so we don't have it here in India. We only have 3 specialties where you can have your DM or DRNB, which is equivalent to the specialty training over there in UK. So we have it here in geriatric psychiatry. We have it in addiction psychiatry. And we also have one, I think, in NIMHANS in forensic psychiatry. And the 4th one might be in child and adolescent psychiatry. But we don't have it here in psychotherapy. So I think it's impressive to see a specialty training in psychotherapy.
Yeah. So basically, it's long hours, lots and lots of seeing patients and counting your hours of how many hours of psychotherapy you've done, etc. People need to have personal therapy as well whilst they're doing that. So it's quite expensive because you have to find your own personal therapy while you're doing that. And as you can imagine, all the time that anybody ever does psychotherapy, you have to have supervision for every case that you've seen as well. So it's finding your supervisor and being able to do that. But yeah, at the moment in the UK, addictions is sort of very hard to facilitate. Lots of addiction services are becoming private and voluntary sector, and we don't have many of them in the mainstream. Where we used to have good training schemes and specialty jobs available in addictions, we don't anymore because the training scheme doesn't allow people to go away and work in private. And lots of addiction services are moving into private and voluntary sector. We are at the moment not recognizing private psychiatrists to come and sort of be supervisors with us. I have my doubts as to whether that's the right thing to do, because if you've got good trainers, you should be able to use them from anywhere. But that's not the system at the moment. So addictions is struggling. It's going to be the same with rehabilitation. We do have an endorsement specialty for rehabilitation, and rehab is again becoming the same. So there's a lot of community rehab, and many rehab units are becoming privatized. And therefore, the consultant provision might be private as well, which means the endorsement specialty is going to struggle a little bit. But these are all things we need to keep in mind. And this is just how things progress, isn't it? Depending on need.
So, from what you said, what I gather is that you don't have the contribution of the private sector in medical education over there in UK? None, none.
Yeah, because it's all National Health Service. So all the people that are trainers are all from the National Health Service. One way of looking at it is whether or not, if you already have people from private coming in to teach and having placements in private, whether people would choose to go private and not contribute back to the National Health Service, which will be a big loss, won't it? So, yeah. There's a lot we can learn from private psychiatry. There's a lot they can input into us, but it's striking that balance.
So I think we are nearing 1 hour, and how much time do you have, Dr. Indira? Can we just stretch for 10 minutes?
Sure, if you've got things to discuss, yeah.
Yeah, so I would like to know your personal journey, because you have done your undergraduation from India and then you migrated to United Kingdom. So how has been it like?
The initial years are really, really hard. I am no different to anybody else. I had my initial years of trying to do PLAB, trying to get a placement. Yeah, so and as you can imagine, at some point when I was doing my internship, I was thinking I might be chopping people up and be a surgeon or something like that. But I think it changed for me significantly. So I was between jobs after my internship, and my grandfather had a stroke. And because I was between jobs, I was looking after him in hospital. And this happened to be that neuro center that I mentioned. So he was under a neurologist, and there was also a neurosurgeon, and the place was run by a psychiatrist in Bangalore. And granddad used to be asleep on his bed. So I just went around and met people, and the consultant was kind enough and let me go around doing ward rounds with him. So I used to follow him and got into psychiatry in that manner. So I worked there for about 9 months. He gave me a job when my granddad was discharged. He had a vacancy. So he said, if you want, come and do the house officer job. So I just joined there. And then I got married and came to the UK, and there was the option of doing psychiatry. So I just carried on from then. So the exams are hard. PLAB is hard. The exams are hard. You just really have to dig in and get on with it. Yeah, but then high specialist training was really nice. I enjoyed that. You learn lots from your on calls. The system's really fair. Everybody does the same amount of on calls and the same sort of exams. Supervisors, well, hit and miss, isn't it? You get some really good ones. People who can tell you how to improve or how to make changes to your face. There are some that don't say anything and just let you get on with it and do their own thing. So I had some really fantastic supervisors, some that were just like, have you got the job done type supervisors. And the point is that you learn from it, don't you? You learn what you can do better for other people. So ever since I was a registrar, what my BST5 level these years, I was so there's a research component in our curriculum, isn't it? We have to write papers, and that was really, really hard. I enrolled for an MD project, which quite didn't get the ethical approval. And then I figured I'd wasted almost 18 months of writing the project up, taking it up for ethical approval and all that stuff. And I went and met a professor who said, well, if it's not research, why not education? And I've been in education ever since. I started teaching undergraduates, went into Liverpool University. I used to do the exams, do lectures for them. The whole of education, all of this bit, it's all unpaid. It's usually sort of just voluntary, you give it your time. And that's what I did. So then when I was appointed consultant, started looking after my junior doctors, and then I took on a tutor post. I was educational supervisor. And then very early on in my consultant post, the director of medical education post was advertised. And they said you had to have been a consultant at least for 5 years, which I wasn't at the time, but I was interested. And I spoke to the medical director and he said, go for it. I'll give you the job if you want it. So I've been director of medical education for about 13 years now, maybe. And I've looked after the scheme. It was so small in the beginning, and then we acquired more and more trust, became a massive trust. There were so many changes. Foundation training came in, and then we had the GP trainees come in. We've also got something called a GP Plus program now. The training scheme is fantastic. So basically, they do 3 days in GP and 2 days in another specialty. So that's your training scheme. So your weekly job is 3 days in primary care, 2 days in hospital and a specialty. So in psychiatry, we get them for 2 days of the week. Similarly, they can be 3 days in GP, 3 days in A&E, in emergency departments. They can be 3 days in GP, 3 days in sexual health, this sort of scheme. So the GP Plus program was a really fantastic challenge, to try and sort of get them through 2 days of psychiatry per week, try to teach them everything that they need to take back. It was fabulous. It came with no funding, basically that's it. We just had them with us for 2 days, and we had to find the right supervisors, find the right jobs for them. Anyway, so through all this, at some point, I started working with a college. There's different faculties in the college for the different specialties, and the general adult faculty is the biggest one, as you can imagine. The general adult faculty has had an opportunity for a specialist advisory committee chair. So that's the person that links in education and services. And I took that job on in about 2018, I think. And then I've never turned back. I've done college work from then. All the college work is voluntary. We give it our own time. So I did that for about 4 years, wrote the curriculum as it stands now, quite a lot of it with my colleagues, and then, helped with the exams, the portfolios, and then I've been associate dean for about 3 or 4 years now. So through that, we've done some changes to the curriculum. So the college surveys everybody annually to check how they like the curriculum, how they like the portfolio, what changes they want, etc. And then based on that, we make changes. So some of the changes I've done, so everything that we propose has to go through GMC for approvals. So what we've done over the last 18 months is brought a bit more rigor into the curriculum and assessments. So I've introduced feedback from patients and carers now, because we have to do that as a consultant. And if a trainee hasn't heard of it all their lives, how are they going to do it suddenly as a consultant, So I've introduced feedback from patients and carers in a small way for junior doctors to start to do it in a formative way when they're training. Then the workplace-based assessment was like a huge Likert scale with like 9 buttons to click. So I've tidied that up a little bit. And then I've introduced something called entrustability scales, which is, yes, people have done so many assessments, people have done so many ACEs, so many mini ACEs, and then you're still thinking, am I going to leave my patient with this fellow, How do you trust this person? So there's something called entrustability, which is very much in use in general medicine. So for example, if somebody does 20 gastroscopies, you sign them off. So you watch them, and if they've done the 20 of them. So, but we don't like to count like that in psychiatry, and we really want people to be capable and competent. So it's not possible to have that sort of an entrustability scale, which medicine uses, medicine and surgery, but we've got something that's a bit more open, bit more sort of accepting, where the scale actually says this person needs supervision all the time. This person can work without supervision sometimes. This person needs supervision occasionally. This person can be trusted to work without supervision most of the times. So that's the scale. And then neither trainer can argue with it, because it's evidence, right? Your supervisor knows how many times you've knocked on him to discuss a case, and other people know around you whether you've done a good job without asking. So that's entrustability scale, which I've introduced. So all of these changes will come in from August this year. Done a little bit on formulation, because as such, you have your balance groups, you have your psychotherapy cases, etc. But people have to still follow that biopsychosocial model in psychiatry, and to evidence that they've actually done formulation skills training and they can formulate a case properly, we did a little quality improvement project, and where a patient has to do case presentation, we've mandated that they put in a good formulation there. So my Tuesday morning teaching programs is usually about 190 people in it. With the case presentations. So you have the audience. The audience can quiz the person on the formulation. There's always a consultant chair, and they can guide them if they've missed anything in formulation as well. And that's become sort of what I have proposed nationally now. I've got GMC approval for everybody to be able to do that. So yeah, I brought in some changes. The direct observed procedural skills, or DOPS, that's obviously for psychiatry, it's just ECT. And that's mandated for ARCP for progression. So for that, it was getting lost within all the other forms within the portfolio. So I've introduced DOPS ECT as a separate thing that people can just like go on the portfolio, check, DOPS ECT 1, 2, done, and then they can sign them off. So small changes like that, keeping it all under check and making sure that we're up to date. Yeah, so patients, so resident doctor well-being and safety is another big thing that we work on, really. Avenues for people to talk to when there's bullying, undermining at work, any issues with supervisor. So on an everyday basis, I have people coming to me as DME with issues at work, nurses being rude or one thing or another. It's my pleasure to do what I can to help. I try my best, and I have a good team of about 13 tutors, postgraduate tutors. I have about 7 or 8 undergraduate tutors that I look after. So I do all their annual appraisals, I do their PDPs, and they have like a rolling program of what they want to learn from it as well. So everybody has to get something back for something, right? So yeah, I like pushing people through. I like to sort of keep the system. So there's Health Education England on the one hand, and there's the GMC, then we have the college, and then we have the local trust. So it's sort of getting that balance of what fits in where and trying to support. And yes, with everything that I've been doing, it feels like natural progression to what a dean might do, to do a bit more, to be able to sort of share what we've got nationally. And what I've been doing as associate dean, it really feels like things that matter nationally, and hence why I'm going to contest to be dean to see whether I can share a bit more. So I have spoken to people across the world as well about the training scheme and what they can learn from it. So Malaysia, Thailand, people that are interested in our scheme and want to learn from it or collaborate or coordinate. In India as well, a couple of people, they had the I forget the acronym they use, but they had the private psychiatrists conference, didn't they, recently? So I spoke to them as well.
It's
Nice to
called
learn.
NSIPS.
It wasn't ANSIP, it was the other one, APPI or something like that. Anyway, one of those. So I learned a lot from that as well. So they actually projected a hologram. So they projected my hologram in their conference, which was amazing. I'd never done anything like that before. So technology is booming in India, isn't it? It's really, really nice to see that they can do such things. So it was really nice. I loved that. First time ever. It's scary to see my hologram, but it was really nice. But yeah, lots of sort of, it's nice to learn and nice to collaborate. And I think a lot of the curricula from Australia and New Zealand as well, they follow quite a bit of the UK curricula, and be nice to uphold those standards and make sure that people get what they want. Resident doctors are very vocal these days, and they're very clear about what they want and what's troubling them. So they don't hesitate talking about these things and bringing them up. We have lots of resident doctor fora where people come in and talk about, what needs to change, etc. On-call conditions, exam conditions and things like that. There's a national psychiatric resident doctors forum from the college as well, where people bring in loads and loads of issues. Why should this be 6 months? Why should this be this? Why should this be this? But that's fine. It's good for people to ask. It's good to empower people to ask. It's good to have that conversation so people know why they're doing what they're doing. So yes, this is me. This is where I am now. I worked as an inpatient consultant for a long time, for about 11 years. And, the use of the Mental Health Act is quite stringent here. And then at some point, it's before COVID, I moved into the crisis team. And I've been a crisis team consultant ever since. Yeah, quite rewarding, quite nice, really. to be able to do. So at the moment, I do 3 days clinical and I do 2 whole days education because I can't do everything I'm doing without actually taking time out for it. So I actually dedicate time to do this and that separately. Yeah.
So, from whatever conversation I had with you on call, on chat, and today on Zoom call, I think you'd be a wonderful person to be the Dean of the Royal College of Psychiatrists. And
Thank you.
I think that would be great if we can have you as the Dean of the Royal College of Psychiatrists.
It's election and only members can vote. So
Yes,
fingers
we
crossed.
wish we could vote, but unfortunately.
Yeah, thank you.
And you are running for dean, then what are the things that you'll be doing after if you assume the position of the dean?
So as I mentioned, the whole recruitment, you mentioned it yourself, the medical training initiative and the bill. So that's key. So I'd have to keep track of it and make sure that by being too stringent, we don't actually lose out and have gaps. So we need to, we need to really embrace our IMG population. The international medical graduates bring a lot of diversity and richness to our psychiatric training scheme, and we need to look after that and support them. The other big thing is exam support. So I told you the pass rate is only about 47%. And the help that people get towards exams is varied in different places. So that's something that I'd need to keep an eye on and support as best as possible. Some of the bigger things that I've been thinking about is rural and remote. So in the National Health Service itself, the consultant vacancies are huge in rural and remote and coastal areas. Everybody wants to be in the hub, everybody wants to be in cities. So I've been thinking about whether or not there might be some merit in having some special allowances to training schemes within rural and remote, which can then retain people that worked with them. So just, there's a college rural and remote group. I'd like to work really closely with them to see how we can enhance that, and whether or not that improves consultant recruitment is something to be seen. Academia is another big thing. I think there is a curricular requirement for people to do research, to participate in things, but we need to make adequate access for them to achieve those as well. And then there's the issue of people sort of falling out of research. So the more you practice medicine and the more you sort of just keep seeing patients, you lose out on evidence-based medicine and the skills that academia brings. So I've sort of penciled out something to think about, bringing back some experienced consultants back into academia, to contribute, etc. So on my flyer, there's a website, and if you see, I've just written a few papers, just outlining what it might look like. There's a big gap between what one proposes and how far it goes with the college, and then you have to get GMC approval for all these things. So that's one thing I was thinking about. The other big thing is stepping up to being a consultant. So from your registrar years to become an independent practitioner and to become a consultant, the burnout rate is quite high there. People really feel overwhelmed at that point, dealing with suicides, dealing with difficulties, moving on and practicing independently, not really having a helping hand. Not everywhere has support groups, peer groups, balloon groups, etc. So I feel like maybe from the college, we need to offer a little bit of bridge. So I've written a paper called the Bridge Program, what I've proposed, where we can put in the final year resident and the first 2 years of consultancy into some sort of program where you have peer support, mentoring, how to deal with difficult issues, how to write a coroner's report, and this sort of backup plan type thing. So I've proposed a paper for that. And that needs a little bit of gelling in and some work as well to be done. The other important thing is, I know I've been saying things about the weekly supervision and blah, 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 but it's about making sure that the consultants have time to do that, isn't it? Wherever I am, I take care of my supervisors really well. I have hundreds of supervisors, and I make sure that I check all their job plans. I do meticulously actually check their job plans and make sure that there's at least identified space in their job plans for supervision, but not everywhere does. And although people want to help, people want to be good trainers, they may not have the space in their job plans. They might just need to keep seeing patients to, take the hit from the turnover with the acute patients. But it's about empowering the supervisors, making sure that their job plans are actually appreciated and respected, and they're given the space to do what they have to do. So that might be one another thing that I'd take a little bit of interest on and support. The Royal College is supposed to approve every job description for every consultant post in the country, but that's all lagging behind a little bit, and it would be really nice to make sure that that's all really really taken care of. For every consultant appointment, there's actually supposed to be a Royal College representative to make sure that the college values are maintained. That's lacking a little bit as well, because how long do you wait for approvals and things to come through when there's a gap? They just apparently are employing consultants without Royal College representation. So it might be nice to sort of get all that back on track again. So there's going to be loads of things on and on. I mentioned the CPD online, the learning that's available on RC Psych Learns is huge, but I'd be really keen to see how many people make use of it, because it's paid. I, for one, don't access it a lot because I only have a very small study budget from my trust, and I have to use it for whatever is worth sometimes. And it might be really useful to see whether there are some really, really important things in there that people are not looking at, and how you increase the participation with college. The members are all sort of distributed across the 4 nations. Do they gel with the college? What can we do to get them engaged with the college a bit better? Because everybody is just interested in their day job, isn't it? And that might be something I look at. So a few things to pick up initially, and then as and when there are challenges, as and when things come up, new specialties, new things to learn, new things to teach. I'd like to keep my eyes open to it.
And you work closely with Dr. Subodh Dave?
Yes. So he's the one that introduced me to doing college work. I'm really, really extremely grateful to him for having linked me up with the college in the first place when I got my the SAC chair post with the college. So I've worked with him really closely from then. And then obviously he appointed me associate dean as well. So yeah, worked really closely with him in the college.
I and Dr. Bhavya met Dr. Subodh last year in December in Jaipur, and we had a small conversation with him. And as you know, that I'm interested into longevity as well. So he is also a long distance runner, and he told me that he wants to be at the, I think he wants to complete a run in Nepal. So I think I was quite impressed by whatever he has to offer. And he's also running for the president of Royal College of Psychiatry. It's,
Yeah. Yeah. I think he's done all marathons all over the world. Yes.
it was wonderful talking to you, Dr. Indira, and
Thank you.
we wish you all the best for your elections.
Thank you so much. Thank you.
Yes, and we wish we could vote for you, but unfortunately.
Thank you. Let me know if I can help in any way. Like I said, if you're doing case discussions and things, I'm always happy to join
Yeah.
in.
Yeah, sure. Thank you. Thank you very much.
Thank you. Bye now. Bye. Thank you.
Bye. Bye.
Bye, Dr. Indira.
Bye-bye. Bye. Good luck with everything you pursue as well.
Thank you.